Okay. Um, so again, my name is Russell. I began my career as a peer support specialist in drug treatment in New York City in 1996 at that point. And kind of, so I've worked as a peer support specialist. I've worked as a case manager. I've worked as a manager. I've worked as an employment specialist. Currently, I'm a director of St. Vincent Charity Medical Center's Rosary Hall. Um, so I've worked in a lot of different positions in drug treatment. And part of what this conversation is about, or what I wanted to get across, is how I think that we pretty much have the tools we need to be effective substance use disorder clinicians. I say that because as a case manager, oftentimes I would perceive that maybe I didn't have something clinical to offer, or maybe even systems around me might suggest that that my work wasn't clinical. I'm going to argue against that in this session, and also argue that there's a lot of things that, even if we're not completely comfortable with substance use disorder treatment, that we can do. One other thing I would, one other thing I would say is I know this audience in terms of first episode psychosis. I was also as director over a young adult program at Frontline for a few years, where it was for young adults who were homeless or formerly homeless, who had a serious persistent mental illness, predominantly schizophrenia spectrum disorders, and a co-occurring substance use disorder. And the things I'm going to talk about, myself and my team felt like were effective with that population as well, and this research would support that. So if I had another title to name this, I would say "Don't Sleep on Empathy," and we will go further. So appreciate that my objectives are appreciate characteristics that generally don't impact substance use. And why I'm focusing on that is we have some kind of, I would say, societal or kind of clinical beliefs about who really should do substance use disorder counseling and who might be better at it. And I might, for some of the research, might actually debunk some of those beliefs. Maybe not. Science is iterative, so we may learn that this is wrong. Also, I'm going to focus a lot on common factors theory. That's sort of a bias of mine. There's a ton of research to support. It's a really helpful way to think about clinical outcomes. But I'll go ahead and own it as a bit of a bias of mine. It's there. You could find literature to refute it. I would say, though, it's pretty tried and true, and pretty much seen as a very supported way of thinking about what we bring to the table that affects outcomes. And then just look at some important specific common factors, and even ways that you can measure that as a team, that evidence suggests with these scales that the higher your clinician scores on these scales, more the research would suggest their clients are more likely to have successful outcomes. So that's kind of what I'm going to try and go through. So probably not a big surprise, but research, and this is an older study, but you'll see I have studies from all across, because I did this literature review about a year ago and went back about 40 years and tried to look at everything I could find. It was quite the project, but I found it really interesting. And so research on substance use disorder treatment suggests that clinicians are a key factor influencing treatment outcome and retention. Not a surprise, but you could also argue, well, is it the intervention, right? Which does play a part. Clinicians typically account for more variance in patient outcomes than do differences between active treatments. So essentially, it seems that, yes, you might have like a CBT approach to SUD treatment, or a 12-step facilitation, or a humanistic approach to substance use disorder treatment. And there are some differences across those treatment modalities. However, the research would suggest the clinicians are actually the bigger factor in terms of the outcomes, irregardless of what intervention they're using. One thing I would say, though, the research suggests what's important as a clinician is you find a modality that makes sense to you. For example, I am a humanist. I do believe my philosophical orientation to the world is humanism, and therefore interventions like motivational interviewing, person-centered treatment make a lot of sense to me. I've since learned things like dialectical behavioral therapy and cognitive behavioral therapy, because sometimes for clients, that's also intuitive and makes sense to them, because I'm only one part of the puzzle. But I think the first kind of task is for you, or if you're a leader, help your team members or your supervisees appreciate what do they believe about treatment, and how does that map in with a particular modality that might be effective? So this is a big study. Y'all have heard about it, Project Match. It's been dissected in a million different ways. And it's, to me, a really interesting study because there's so much effort put into it. The rigor is pretty rigorous, and it was a thoughtful study. So basically what they were doing, they were trying to look at, randomly assigning 1,700 folks. It was a sort of a random assignment. People came from multi-sites, so they were randomly assigned within sites. You can't say it was a true randomization because it wasn't across the population. It was within sites. They randomized to 3 different psychosocial treatments for alcohol use disorder. So 12-step facilitation, cognitive behavioral skills training, and motivation enhancement therapy, which is motivational interviewing with some assessment added to it. And like it says, because clients weren't completely randomly assigned to therapists as well, you can't definitively establish that differences in client outcome were because of therapists, right? But there's research, some of the findings suggest that was the case. So within treatment, so within 12-step facilitation or CBT or what have you, after controlling for site differences and client baseline drinking, and readiness for change, they found that therapist effects continue to be significantly rated to client satisfaction and drinking outcome. So that's irregardless of what modality they were using. And therapist effects were also consistent across time. So the impact of the therapist, when you looked at them at 3 months and 6 months, the effects seemed to hold. So the effectiveness of that counselor seemed to have some legs. And this is what I find really interesting, and lots of research supports this, that essentially the therapist differences were generally about outlier therapists, either an outlier who was significantly better than their peers, or a therapist more likely who is significantly underperforming their peers. And I'm going to say something that might be radical to some people, but a lot of the movement towards manualized treatments were because we know there are people who are clinicians who have a hard time being effective. And a manualized treatment helps get them to a certain baseline, right? So that they're not performing significantly poorer than their peers. There are other reasons, obviously, to have a manualized treatment. It's easier to study and research. It can be intuitive to clients. Again, it's very predictable. They know what's going to happen. So there's a lot of benefits of manualized treatment. But one of the big ones is that it brings everybody, it lifts all the boats up, so to speak. Your poor performing clinicians will be better. So, just as one example, one MET, motivational enhancement therapist, showed particularly low rates of client abstinence, whereas another therapist had clients with unusually high drinking intensity. And that's a trend where you'll see the outliers are typically lower performing people. And typically what research suggests, and when they look further into this, into Project Match, it seemed that the poor performing clinicians, their clients didn't believe that they were very empathetic, nor did they have positive regard for them, which I think is the other thing about substance use disorder treatment that's a little unique, is that in the United States, substance use disorders has been intertwined with morality since the beginning of our nation. And therefore, sometimes we will say things like good, bad, dirty, clean, and have beliefs about people with substance use disorders, unlike people with type 2 diabetes or hypertension, and maybe even some serious and persistent mental illness. Obviously, serious and persistent mental illness has its own issues, but in terms of prejudice and stigma, but not as much the morality piece, I would say. So there are a group of people for whom it's just they don't think highly or think positively of people with substance use disorders and think that they're immoral. And I've heard referred to as criminals and things like that, right? So they're probably not going to be very effective. So one thing that we thought, and I'm a psychologist, so I tried pretty hard to get a degree, right? But really the research suggests that our professional characteristics don't make much of a difference. And there's a famous study where a receptionist in a psychiatry office had some basic training about diagnosis, and they were able to diagnose as equally well as a psychiatrist after a little bit of training. Obviously, a psychiatrist does a lot more than just diagnosis, but it kind of speaks to a little bit about some of this is a little bit intuitive to people. Obviously, there's sort of a baseline, like typically having been in the field for a couple of years and having adopted some modality, right? But once you've kind of gotten to that place, it's not a big difference in outcomes between a bachelor's level clinician, a master's level clinician, or a doctoral level clinician in terms of patient outcome. Demographic matching in terms of like putting people together racially. One thing you want to think about with this, there is research to suggest that the racial identity development of the clinician is a strong predictor of outcomes with working with people of different races. So if the clinician has done work with themselves on their own racial biases and prejudice and perhaps even their own racism that they're working through, if they've done that work, they're going to be able to be as effective as a same race clinician. If they have not done that work, they will not be able to. But race itself is not a predictor, nor gender. So 1998 study with 900, one thing I'll say, I'm a little flustered. My son was diagnosed with COVID yesterday. And I've had 2 losses recently, and I'm realizing like I'm a little bit like blah. But anyways, so Sterling in 1998 studied 967 African-American cocaine-dependent outpatient folks and found no relationship between clinician variables like race, gender, and training in treatment retention, which echoed other studies with 630 cocaine-dependent patients and echoes a lot of other studies. Again, racial identity is a predictor of retention, satisfaction, outcome. Race itself is not, or nor gender. So clinicians in recovery, oftentimes people believe, well, it really should be the people who are in recovery. And by the way, I'll also acknowledge that I'm in recovery from substance use disorders. So there's a kind of belief, well, they're going to be the best at working on it. And sometimes clients will say that too, right? Like, I want to work with someone who's had a substance use disorder. And then that's their preference. And you would probably want to match that as best you could, if you could. But basically, there's been 50 studies on this topic, and they have found that there's not really differences between those clinicians who are in recovery versus those who are not in recovery in helping people with substance use disorders. A clinician adherence to treatment fidelity. So essentially, there's increases in their effects on outcome lessons. So the more that a person is, I'm sorry, that thing was in my way. So increases as a clinician adherence to treatment fidelity increases. So as they get more consistent with the treatment modality, their effects on outcomes lessen, according to a major meta-analysis, which essentially suggests that if people are adherent to the modality across clinicians, that there's not going to be differences. And that's sort of my point earlier, that why manualized and structured treatments can be helpful, because if everybody adheres to them, then those differences across clinicians wash away, because now you have kind of, I guess, sort of firm clinical grounding to stand on if maybe you're not the strongest in terms of empathy and other types of personal factors you bring that could be effective. And again, this is why we think that it is helpful to have standardized, manualized treatments, one of the reasons why. So I talk a little bit about common factors theory. So it proposes that different approaches and different evidence-based practices in counseling share basically common things. If you boil them down, there's kind of similarities. And that those common factors are what account for much of the effectiveness of psychological and/or substance use disorder treatment. So basically from the beginning, it was suggested that there are certain factors that are common to all things. So some of them are inside, some of them are the ones in dark, I think, yes, the ones in dark are what the client brings. So the degree to which a client has insight and ability to have insight, that's going to affect clinical outcomes. Meaning making, the degree to which the client's able to make meaning of the service and of their treatment, that's going to be the degree to which they feel connected on their own to you. The degree to which they perceive a therapeutic alliance, their expectation. Basically, there is a placebo effect in therapy, right? If they think it's going to work, like medications, it's going to be more likely to be helpful, at least in the short term. There's a certain aspect of myth and ritual, and we can think what we want to think about that, but people across time, across culture, across everything, have for whatever reason decided that healing oftentimes and spiritual awakening and connection involve a myth and ritual. There's a reason why human beings gravitate toward it, and therefore it seems to manifest itself in counseling, in people who kind of get with that and kind of believe in this ritual is important to me, this process and this interaction with another human being and being vulnerable, then that's effective. And the idea of a corrective experience, that the degree to which the client believes, wow, this really did modify my relationship to people, right? I'd had bad relationships with people, and here's a human being who treated me with positive regard, and I feel connected to them. And insight's so important, I put it twice. But in clinician characteristics that we bring, and these three are the big ones. And what's interesting is they're all in motivational interviewing. Wild. So collaboration, empathy, and positive regard. So the degree to which a clinician is able to collaborate and partner with their client, empathy, and I talk about this all the time with people, the degree to which the clinician is able to walk in the other person's shoes to some degree understand their experience. In substance use disorder treatment, I would argue a lot of times in therapy, we want to meet people or be empathetic. I'll just put it on me. I want to be empathetic and meet people where they're at for about 5 minutes, and then I want to start telling them how they can do things better. That's not really empathy. Empathy is really taking the time to understand a person's experience. And the argument is the process of doing that helps the person understand themselves better, and they begin to see their own incongruences, and they begin to ponder their own incongruences because you've given them the opportunity to learn about themselves as they're teaching you about them. And positive regard, just having a belief that the people you're seeing are generally good and generally want to be better versions of themselves. I was doing a training here at St. Vincent at Detox recently, and I asked folks, do you spend as much time catching people bad as catching people being good, right? And in substance use disorders, we love to catch people. I love to catch people lying and, manipulating and those things that we say. Do you put as much effort into acknowledging and recognizing and celebrating all of the positive things they do? I think in substance use disorder treatment, sometimes we don't do that. We focus on the less healthy behaviors, we'll say. So this is a big meta-analysis from 2014. And this, where they look at a number of different randomized clinical trials, and it suggested that 11.5% of the variance, so 11% of therapy outcome was due to goal consensus and collaboration, which is probably why all of our individualized service plans necessitate collaboration and patient input, right? I'd say sometimes we really do that in earnest and sometimes we don't. And I would argue that if you're really interested in making it more likely the client's gonna have a good outcome, you probably wanna really do due diligence and I know it's hard. I was a case manager, like I mentioned. I had a caseload of 30 people who were homeless and had multiple challenges and barriers. I'm not saying I was perfect at all. Looking back on it, I wish I could have done better in this arena. But I think that's something we want to think about. 9% of that outcome was due to empathy, the degree to which the patient believed that you understood them. 7.5% was due to therapeutic alliance, the degree to which the patient and you felt connected to one another. 6.3% was positive regard and affirmation. Basically, you were catching them being good and acknowledging their strengths. And you can see the rest, but I kind of where that leads me, and again, there's many studies that have shown similar things, is that goal consensus, collaboration, empathy, alliance, and positive regard. Those are probably pretty important things to think about in your team and in yourself. And how are you promoting that with your training of your staff? Again, these findings are consistent with reviews of SUD outcome literature, which again show collaboration, empathy, and positive regard are important factors. And so how in the world would you maybe look at this, right? So I do love motivational interviewing, but what's interesting is that for randomized clinical trials of motivational interviewing, you have to basically know if the client got the intervention, right? It's not like a medication where they got it. Did they really get motivational interviewing? So they've created the Motivational Interviewing Treatment Integrity Code. This is the 4th iteration of it. And what it shows is and it's all it does is look at the clinician. It's a behavioral anchor thing. Like, okay, they did this many open-ended questions, this many affirmations, this many reflections. I used it when I was teaching the medical students at Neomed. And essentially you just, you watch someone do it, you rank them, you talk to them about it, but the research would suggest the higher they score on it, their clients are more likely to have positive outcomes and over time. So some of what it really looks at, like they have these global rating scales where it's cultivating change talk, that's trying to get the person to talk themselves into change, softening sustained talk, when the person says they don't want to do what you're telling them to do, empathizing with that, basically, collaboration and empathy. Those are four of the big factors that you look at that, again, have been shown in over 30 years of 30 years of research that predict client outcomes. So cultivating change talk, I talked a little about that. I know I got a roll. Softening sustained talk, non-judgmental, being empathic, partnership collaboration, agreeing on goals, agreeing what we're doing, and accurate empathy. Basically, not only just thinking that you're empathetic, but checking it out with your client or patient through empathic statements. And then they have the opportunity to correct you or to say, no, that was right what I was saying. And this is basically what you do. When you hit competency and proficiency, again, the research would suggest your clients are more likely to have positive outcomes. So you're scoring high on those global ratings, you're doing a number of reflections, you're doing a bunch of open questions. And basically, you're not telling folks what to do, you're collaborating with them and being positive and affirming them. And that's, there's a ton of studies. I really went through all these. So if you're interested in knowing how I came up with this, that's it. And thank you all very much.